thank you very much for having me and inviting me to this conference. As you can see, I have two hats, so I'm only a part-time researcher, unfortunately, these days. So I run a large platform which is looking at imaging, and if you want to do imaging in large animals in Melbourne, please come and see me. It's a very powerful technology. But my research job is at the Australian Centre for Blood Diseases. I run a lab which is focused on antibody engineering and nanotechnology, and that's why we'll talk about really our work in the area of fusion molecules, so targeted thrombolytics, and also smart nanoparticles for drug delivery. I don't have to give a lot of introduction. A lot of things have been said already. But I think in the area of thrombolysis, time is brain and time is heart. So in both indications, the earlier you can intervene, the more benefit you get for the patient. And Bruce already introduced these stroke units. Now I think there are efforts in Melbourne to put CT scanners into helicopters as well to reach other parts of Australia, to also have the same capability as in the major cities. And in the way of introduction, I always highlight this case report, which was published a few years ago, which is quite interesting, around someone in Western Australia, 1,000 kilometers away from Perth, a nurse who realized that he had a heart attack. And he basically sent his ECG to the next hospital, confirmed that he had a heart attack, and canalized himself and injected TPA into himself. And basically had a better outcome. That was clear, but also in the paper, at the end it says we wouldn't recommend self-therapy if there's medical therapy available in a timely fashion. Yeah? So that really shows the dilemma if you're in Australia, if you're far away from the major centers and you have a major stroke or major heart attack, it's really problematic. So my lab has been really focusing on making thrombolysis more powerful and more importantly safer. And we do that mainly by targeting. So we're really fans of fusing thrombolytics to antibodies or other modalities to really bring the active ingredients to the clot and spare all the systemic circulation. And that was really highlighted in this editorial of a paper we published now nearly 10 years ago about bringing urokinase, in this case, to activated platelets. And I also realized that the first paper in this topic, fibrin-targeted urokinase, I published nearly 20 years ago. That shows first my age, and it also shows how difficult it is to translate things in this area. I will talk a little bit today about the activated to B3A targeted urokinase, which we now tested also in stroke, which is very interesting. We also did some interesting molecules where we swapped the activation site of plasminogen for thrombin activation site, so thrombin activatable plasminogen. We also did some nanoparticle work around microbubbles and also other nanoparticle formulation, which I will talk about a little bit as well in the second half of the talk. I don't really need to introduce platelets to you guys, but they're really, really cool, I think. And these are some pictures, not from us, but from another paper, that they're really like macrophages. They can crawl from A to B across a chemotactic gradient. They can collect bacteria and really phagotize, and they're really immune cells, as you know now, seen as immune cells, as well as cells in the hemostatic system. We are mainly interested in 2B3A, main fibrinogen receptor, and an antibody has been made which are used extensively against GP2B3A only in its activated form. That's very important, so you only want to target activated platelets. It's specific for platelets. GP2B3A is highly abundant, of course, so it's an excellent target for drug delivery, and you have, of course, this two bend and close conformation and the open conformation of 2B3A to really make an antibody specific to the activated form only, and that was done a long time ago by phage display. So phage display is a way to ex vivo generate antibodies against the target of choice. So we did that, not we, but the company in Germany, collaborating with my former boss, they generated this antibody by doing panning, so selection on non-activated and activated platelets, and CHO cells which had the activated and non-activated receptor expressed on the surface. So two different cell systems, panning, so selection over multiple rounds. And what you end up with is really an antibody which only binds to the activated form of the 2B3A receptor and not to the non-activated form. And that's shown here in flow cytometry, that it's exquisitely selective for the activated form of 2B3A compared to the clinical approved antibody exipsimab, which binds to all platelets. And how well that works in vivo, we really found out with this intravital microscopy picture, and Connie introduced the intravital already. So these are iron oxide, autofluorescent iron oxide particles, which are tagged with our antibody, and then you make an injury to the vessel wall. And within seconds, basically, of injection of these targeted particles, you see that in this vessel they accumulate at the site of the thrombosis. So that was really the first way where we could really nicely show in vivo how specific and how fast this targeting is. So the first paper, which is also published a while ago, was this fusion of this antibody to urokinase in a setting of normal thrombosis in the ferrochloride artery injury model shown here. It's quite of a busy slide, but the take-home message here is really that you get good thrombolysis with 500 units of urokinase per gram. You get similar amount of thrombolysis here in red with 75 units of urokinase per gram. So with less active drug, you get the same outcome when it comes to clot resolution and clot removal. But on the adverse effect side, so the bleeding side, you see that the 500 units of urokinase give you a massive bleeding phenotype, and the lower dose is as effective as the high dose, will not give you any bleeding complications. So we think that this combination of an antibody with urokinase is not only efficient, but it's also safe. And that's also shown here in this video. So this ultrasound pictures, I hope the second video starts as well, where you can remove this clot very specifically in the carotid artery, and the mutated control is not doing anything, and that's just quantified here. So you have your control and your non-targeted urokinase, and then you have high-dose urokinase and also the targeted urokinase, both efficient in removing this clot. So Rob was involved in this work at the time, because one of the reviewers said, can you be sure that it's specific for urokinase? Is your anti-2B3A antibody is not also doing something? Because you all know that high doses of anti-2B3A could potentially also dissolve a clot and break up the structure. So the reviewer asked us to do this in a plasminogen knockout mice and then infuse plasminogen, so which really shows that it's specific. So these mice don't have any plasminogen, so if you inject that, you don't get the thrombus removed until you give a bolus of plasminogen, and suddenly the system gets activated and removes the clot. So the newer work around this is really in stroke. So the same construct, the 2B3A targeted urokinase, we tested in stroke quite recently. And the idea is not only to more efficiently remove the clots, but also avoid all the detrimental effects of TPA onto the blood-brain barrier and the vasculature. So really to have more salvageable tissue in this model. And I don't really need to introduce that, because Connie and others did that already. So the model we are using is this photothrombotic stroke model. And Brett, who is here, was really instrumental in setting that up in the lab and helping us a lot to get this model up and running in our lab. So if you inject the targeted urokinase compared to non-targeted urokinase in this model, you really see a big benefit compared to TPA. So we quantified that in CT and in MRI, looking at the brain damage, and that's also quantified here. So you see less infarct volume compared to vehicle, but also to TPA. You see less blood-associated deposits, and the infarct volume is also affected. And what's very important, going back to Connie's point about immunosuppression, so you also see less immunosuppression in these animals compared to TPA, because TPA, of course, has other effects which are really detrimental on the outcome. So we looked at albumin infiltration and brain hemoglobin, so that's more like the blood-brain barrier breakdown, of course, but also white blood cell count, spleen size, and platelets. And they're all pointed in the direction of that the therapy is much safer than TPA. because it's urokinase, it's not has this detrimental effects TPA has. And we're not relying on the fibrin specificity because we are targeting anyway with an antibody against platelets. So we don't really need the fibrin specificity of TPA. The last slide on this is on the neurological benefits. So here again, after 1 day, you see a dramatic improvement in the neurological deficits of these mice, and we also did all the total foot slip time and duration and time traveled, and in all of these tests, and it's all in the paper which was published last year. You see that there's a substantial benefit of using targeted urokinase compared to TPA in this stroke model. So I'm going with time. So I shift gear now a little bit to nanomedicine. So this was mainly the fusion molecule work we have been doing for a while. So nanomedicine, I think we will have a few talks in this conference talking about smart delivery, and we heard this nice platelet talk this morning as well, which are kind of nanoparticles as well. If you strip platelets of the interior, you end up with a targeted particle. So we're doing a lot of work in this space as well. And we are using, as I mentioned at the start, thrombin as a trigger to release the drug. So effectively, we are hijacking the coagulation system to introduce thrombolysis. So we did that with the activated plasminogen, where we put in a thrombin activation site into plasminogen. And with this particle work, what we are doing is we are making nanoparticles which have a peptide linker, which is sensitive to thrombin. So when thrombin comes in, this peptide linker is chewed up, and the particle will dissolve, and the thrombolytic drug is inside and released. So we think that it's a pretty interesting way to do this kind of work. We're working very closely with Franco Russo at Melbourne University, who is one of the big guys in nanomedicine worldwide, and he's one of the fathers of layer-by-layer technology, which is a very complicated, and I come to that later, but very elegant way to make nanoparticles and make responsive nanoparticles. So you have different polymers which are differently charged, and you put them one after another just by physical absorption and static interaction. You do 4 or 5 of these layers, and then you cross-link these layers in between to make them responsive, and then you put antibodies on the outside of these particles. We're using a technique which is called Sortes bioconjugation, which is an enzymatic way to attach antibodies. I don't have time to go into all the details, but it's a very nice way to site-specifically attach antibodies to nanoparticles or to any other non-biological structure, because you don't really want to have antibodies randomly attached on the surface of your particles. You want them specifically attached to the surface in a coordinated way. So these particles are basically mesoporous templates, which you fill with UPA, and you can put everything in. So that's the beauty of this system, of course, that you can put in UPA, you can put in potentially DNAs as well, and load this with multiple active ingredients. Then you put your layers around, cross-link them, put antibodies on the surface, and that's the sequence here we're using. So this is the thrombin activation sequence, and this is just the inert sequence here. And then in vitro, when you test that, you basically get a rapid release when you add thrombin. So these are these particles just in an in vitro assay. You add 1 unit of thrombin, and you see immediately that it starts to degrade more rapidly the higher you go. And if you go to, nobody really knows what the thrombin concentration is in vivo at a clot. But we think that 5 to 10 units is probably a good estimate. So with 5 to 10 units of thrombin, you get this rapid degradation of these particles. We decided not to pursue this further because from a translational point of view, and that's why I asked this question about storage and things like that in the other talk, these particles are very hard to make. You have to basically physically put layer onto layer into layer, and then purify it, cross-link, put the antibody on. So I think from a pharma translational point of view, to bring that into the clinic, it's really not a feasible technology. It's nice science, and it's really cool nano stuff, but it's not really something where you see that anywhere going into the clinic. But it shows the concept is sound. So the next thing we tried is to make that more simple. So 1 step, 1 pot, generation of these particles. So again, we made a mesoporous template, but then we only coat this with a peptide coating, and we put tannic acid, which is like a glue, onto the top. So this will all assemble in one pot when you put it together. So you get your system up in pretty much a few minutes in mixing in a tube. So we use this PEG-like structure, which is called PAS, or proline alanine serine protein, and it's also again cleavable. So we have the cleavage site for thrombin. So the shell of these particles is also responsive to thrombin. And that's just some characterization how they look like. I think it looks always, when I look at these pictures, it looks really, really amazing. So these are the particles when they are made. This is the particles when they are filled with the drug. So you see that there is now drug loading inside. And these are the particles when they are coated with the shell around it. So that was the characterization how we make these particles. And they are not as responsive as the layer-by-layer ones, but they are responsive, and that was really, really important for us. So they don't really fall apart immediately, but they're still, when you increase your thrombin concentration, they are responsive to thrombin, and that's probably a way forward with these particles, and we're trying to test them now in various animal models of disease to see what they do in vivo. So they are easier to make, more translatable. The last part of the talk is around a system we haven't published yet, which is a bit different nanoparticles. These are nanoparticles are not made like a classical way by layer or polymer chemistry. These are porous silicon nanoparticles, which are actually made on a silicon wafer. So you have a silicon wafer, you etch the surface, and then you break little fragments of the silicon wafer off this template, and these are your particles. So they're little fragments of this silicon wafer after etching and sonification. So they look a little bit like this. They're porous, highly porous structures, so you can load drugs inside, and then they have an amine surface. And what we're doing with this project is similar to the other ones. We load this with a drug, in our case urokinase, but you can load whatever you want. And then we put this protein brushes on the outside, so really have a spherical barrier of the drug filtrating out. So that's kind of our way to encapsulate the drug inside. And again, we have thrombin cleavage sites around it. So when thrombin hits the particle, the idea is that this polymer or protein brush coating will be released and come off. And a little bit of chemical characterization around it to see that they're all homogeneous and we can functionalize them on the outside. And then we have, of course, an antibody as well against 2B3A on the outside. So we have targeting, we have the thrombin responsive linker, and we have the drug load on the inside. So that's a project which is ongoing, and the characterization is ongoing before we move into in vivo with this particle system. And you can see that they bind to activated platelets, and we are doing drug release studies at the moment. So that leads me to summarize what I showed you today. I'm a firm believer of targeted drug delivery, that this is an approach with really great potential to reduce cardiovascular burden in MI, but also in stroke. The technologies we have developed could have a significant impact on hopefully progressing this field. I think we need better thrombolytics, and one way to bring thrombolytics to the thrombus can improve that. The nanoparticle work is challenging. It's very hard to translate because there are issues with scalability, biocompatibility, also get the balance between the leakage of the particles and the responsiveness right. So they can't be too responsive because then they will leak easily, but you also want to have a quick release. So future work, as I said, for both of the system, the one pot assembly and also the porous silicon nanoparticles, is to test that in vivo. That leaves me thanking my group and my collaborators, so mainly Frank Caruso. I worked a lot with Paula Karl-Heinz Peter in the past, Nico Völker on the silicon nanoparticles, and Rob was involved in a number of the projects, and he's doing this fibrinolysis assay with the plates himself. I can attest to that because you did that for one of the papers. Funding bodies. I'm also, as a platform director, very thankful to NCRIS, which is a big national infrastructure funding body in Australia, to give us all the nice equipment, MRI scanners and PET scanners to do all the imaging work. And two slides to advertise a little bit. So my role mainly now is Director of Monash Biomedical Imaging. So if anyone here in Melbourne or outside, at least in Australia, needs access to human or animal imaging equipment and expertise, please talk to us. We have a number of preclinical systems, MRI, PET, ultrasound, but also we have research-dedicated clinical systems. So we have dedicated 3T MRI, PET-MR, and also CT for humans, which are only for research. So we don't have the pressure of getting patients onto these scanners. So that's really good for clinical trials or something you want to do. And if there are any antibody interested people in the room, Monash is organizing every 2 years a lovely antibody conference in Prato in Italy. It's as nice as Bayern, I would say. It's very nice in Tuscany. So that's happening again in September next year, organized by my colleagues Remy Robert and Karen Alt. So if you're interested in antibody fusion molecules or antibodies, please check out this conference. Thank you very much.